Good luck with this. Let's go.
Well, we have about 10 minutes of question and answer. This one is for you, Peter. When is cholesterol too low? Ever need to pull off if it is too low cholesterol? You mentioned that a bit.
Yeah, I did. You know, when is the cholesterol too low? I think that with the data we have up to this point, we're talking more LDL cholesterol. I think if you get to 25, 30, 35 milligrams per deciliter on a stable, tolerated treatment regimen, it's okay to stay on that regimen. No reason to cut back on the dose of the statin or any other medication. You know, some patients are hyper responders and they will get that low. The only way you're really going to get down to 25 or 30 is using the injectable monoclonal antibodies. Those are usually much higher risk, probably more genetic patients that need to take that kind of treatment. But most of your oral drugs, it's hard to get down to 25, 30, or 35 anyway. So I wouldn't stop them if they tolerate any of their medications. Low LDL is good. The lower the LDL, the better. And I would just have them take it for the rest of their life. That's your job, is to make adherence work.
Where can I find the new risk calculator for my patients? I think this is an important one for you. It is on the App Store, irrespective of what device you have. And if you look at risk calculator, it usually comes up with a heart and it says ACC-AHA risk calculator. I think it's great. It starts a discussion. Don't take these numbers as, you know, gospel. You have to look at the whole thing because it has some of the risk factors, not all the risk factors that Peter has mentioned today, but I think it starts a discussion between you and the patient, and those who are on borderline, you may use a calcium score in addition to just add to your discussion with your patients.
Yeah, you get it from the ACC website?
You can actually go to the App Store.
Yeah, at the App Store, it's pooled cohort equation, PCE is what it is.
Yeah, but I would add that we really have moved into an age where we're going to be using risk scores for multiple things, for surgery, for duration of DAPT, for bleeding risk, for anti-lipid treatment, for virtually everything we do. It's all going to be app-based. You know, the models are complex. The models are not simple. You're not going to be able to tick things off on the back of an envelope while you're in there with a patient. You got to say, okay, let's whip out our cell phones. I'll race you so you can get to the app first, because patients are going to do it also.
And I think that applies to almost anything. Why do you have a risk score, or why do you have anything? It's just trying to pool data that, you know, whatever we do is multifactorial. So you're trying to bring data together. This is ultimately where artificial intelligence and machine learning would come into imaging and putting your clinical factors and putting so many other things together to try to narrow down, you know, whatever risk is, because everything is multifactorial that we deal with. All right, a 30-year-old healthy female with LDL 19, I'm probably maybe 190, on no meds, a strong family history of heart disease. Anything need to be done? 19?
Okay. Yeah, well, you know, obviously she's got one of those, you know, low LDL genetics. As I told you, there are patients who inherit low LDL, and it's a good thing. A strong family history of heart disease, it is an interesting one. The question is, what are the potential other risks? From a lipid standpoint, I would check Lp(a) just to see if that's one of the genetic tendencies that person may have. But also just make sure they don't smoke, don't get obese, you know, change the things that they can alter. But at least from a lipid standpoint, that probably is, at least from the LDL standpoint, not the issue. I was thinking it was 190
yes,
because of the other side was, what do you do with young people who inherit high LDL? And the question is, that's a lifetime risk, and it is an important discussion to have on the other end, is what do you do with a 30-year-old for very high LDL, particularly a female, where you have pregnancy issues and the chances of getting pregnant. You know, how do you treat and how do you manage the drugs during that kind of situation? That's an important discussion to have. We've treated many women during childbearing years on statins. As I've always told them, I said, I wanted to be the second person that knows you want to have a child. And we will stop the statin prior to whatever you're going to do to get pregnant, and then restart it after your breastfeeding is finished. And do statins in between all your pregnancies, and we've done that for women with genetic cholesterol problems.
Is it worth to treat SAMs with NSAIDs?
Yeah, muscles with ibuprofen or NSAIDs. There are a lot of patients who say, I think the statin does cause me a little bit of a problem, and maybe it's mixed with other things like calcific bursitis or a bad knee. Yeah, I mean, if they'll take the statin because they take ibuprofen or acetaminophen, yes, if they'll keep them on the statin, and I think that's okay.
Neal, is it better to give newer antiplatelet over Plavix?
For acute coronary syndrome, the answer is probably yes. We've got to be a little careful. Ticagrelor and prasugrel are the new antiplatelet drugs. So far, I think probably permanently, it looks as though prasugrel or Effient should be used only when when the patient's having a PCI and getting a stent for their ACS. If they're not getting a stent, it probably is detrimental rather than beneficial. Ticagrelor, at least as it's been studied, is more widely usable. The benefit appears to be present in the Plato trial among patients who did or did not end up getting cathed and intervened. So the answer is generally yes. Largely, it's a question of what can the patient afford. And, if you think their bleeding risk is higher than average, based on those apps we briefly discussed, you might be better off with clopidogrel.
And I'll follow that with a question. Let's say put them on ticagrelor for a year or two. Do you switch to a generic form?
Well, that's the only generic
I'm talking about,
is clopidogrel.
That's what I'm talking about.
That's a wonderful question. A lot of people do. There aren't any data to support it. My view has always been that, we have these big trials that are pretty meticulous. If we're going to use a treatment because there's a benefit shown in the trial, it makes the most sense to use that treatment as it was used in the trial that we
would continue
based to choose it. So I would continue it. Now,
okay.
People develop side effects. The big thing we see with ticagrelor is dyspnea that we really don't have a good explanation for. In those patients, we switch, no question. But otherwise, I try very hard to keep people on the medication they were started.
Okay, two other questions for you that I can think from a clinician. One, GI doctor, maybe some have here, say, well, stop Plavix and aspirin before the colonoscopy. If somebody has had a PCI a year ago, you would, number one, would you wait for a year to do anything like this? And would you do it on Plavix and aspirin?
Okay, so surveillance colonoscopy. The answer is wait. No one has their age 50 colonoscopy at 50. It takes at least a year to get your courage up. So if it's a surveillance colonoscopy, just wait. If it's for clinical indication, then there's some negotiation. I usually I try to tell GI docs, look, why don't you do the diagnostic colonoscopy? There's a 50% chance you won't have to biopsy. And if that's the case, if that's the case, we're saving the patient the risk of stopping the medication. If you do have to biopsy, why don't you rescope, and at that time we'll have stopped the Plavix. Then the negotiation comes up, how long? The truth is, if you look at platelet function, after 4 days, you've dumped enough platelets back into your circulation so that you can get hemostasis, and there's still a little bit of protection left. Negotiating that's not always so easy. Sometimes I feel if I've got through that successfully, next stop's the Middle East, and I'll settle things there.
All right. Well, I want to thank both of our speakers for really amazing presentations, and we'll go on to the next session.
Thanks.